And can I have each one of you come up with, like, for a couple of lines, just for a couple of lines? I won't keep you up here the whole time because you want to take notes, I know that. But just for a couple, I need a volunteer, I need a serious patient, is what I'm trying to say. So, can I have a number one volunteer? Is that you? I saw sister moving. Number one, number 2, 3, 4, 5, 6, 7, 8, I want 10. 9, thanks. 10. So the I'll try to keep it going. Sister, you're on board. And I think what I'll do, sister, I'll just have you sit up here on the table. Now, all this, you know, you start with washing your hands. Okay? So there's a sink in the laboratory. Or if you want to catch the washing, you want to save some time to wash your hands just before you come into the exam room, that's fine too. You can tell me, I'll trust you. You can tell me, I just wash my hands coming in here to take care of the patient. So wash my hands, explain to the patient what you're going to do. So sister, today, let's do the whole thing. Sister, today I'm going to check vital signs, I'm going to check respiratory, and I'm going to check cardiac function, okay? Okay. Okay, good. And I've got a willing voluntary person here. All right, so our general parameters for this thing, on page 9 of the comprehensive assessment, that's the expanded version. This is not the listen to the heart at the apical. This is not just listen to the heart at the apical, like you had the quick and dirty. Yes, right? Yeah, making connections. This is an expanded. We're going to listen to a lot of places in the heart with the diaphragm. What are we listening to? What pitch of heart sounds are we listening to with the diaphragm? We're checking out any high pitch sounds. Then the last one, we're going to switch over. We're going to listen to the bell. And of course, we're listening to low pitch sounds. So we're going to listen to the heart 3 times through. This is the expanded. Have you seen any provider yet listen to the heart through those sequences 3 times? See anybody do that? What do you see them do? Put the stethoscope down somewhere, right? The best place if you're going to do a quick and dirty is the apical, because that's the strongest place where you're going to hear what's going on with the heart. All right, now our parameters here is rate, rhythm, depth, effort. Oh, I'm on the wrong one. Excuse me. 9. S1, S2, appropriate relationship. And you know what that sounds like. You know when I had you pull the stethoscope out, just for fun to have you play with the stethoscope so you could feel official with putting a stethoscope in your ear and doing this, right? You remember when I had you go up here, and then I had you go down here, right? I was trying to build on the future. When I had you go up here, you heard bump, bump, or bump, bump. Joseph says the first one you did. Bump, 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 bump. And down here, you heard the second one. Go. Yes, do it. Bump, right? And why is that? Why is that? This part down here is closer to what set of vowels?
The semi.
I heard it. AVs, the atrioventricular, which are AV valves are the tricuspid and bicuspid, or mitral, right? Bicuspid is also mitral. You know that, right? Mitral, bicuspid, synonyms for the same thing. Up here, when you're listening up in here, what valves are you closest to? Closer to? Your semilunars. And so you've got S1, S2. The first sound, the second sound. The first sound, the second sound. If you're closer up here to the second sound, it's going to sound louder. Boom, 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 boom. Down here, boom, 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 boom. That's the appropriate relationship of S1 and S2. Are you with me? Does that make sense? All right. So the first thing we want to pick is, do we have the appropriate relationship of S1 and S2? Is there a question in the back?
S1's on the bottom, S2's on the top.
That's right. S1's on the bottom, S2's on the top. All right. So appropriate relationship of S1 and S2, we're going to be listening for that. We're going to be listening for the rate. Our cardiac rate should be what? You learned? 50. Did you say 50? Good. Yeah, you're right. 50 to 90. So if we're saying the pulse should be 50 to 90, your textbooks is saying that. I learned 60 to 100, and I told you about that disparity. Okay. Your book is saying 50 to 90, 50 to 90. Actually, I think the book is more right. If someone's clicking on 100, if they get up to 96, 97, 8, 98, and 100, I'm worried. I should not see someone resting there clicking away to 100. So I actually agree with your textbook. I think it's more accurate in saying 50 to 90. All right. So if you get a pulse there at 50 to 90, it makes sense the person, I I shouldn't say the person, the organ within the person who made that should be the same thing, 50 to 90. Are you following? And then I ask you way back when, boom, boom, how many beats is that? Boom, boom.
One.
You sure?
Yeah.
Yes, just one beat, okay? Like in and out is one respiration, okay? An appropriate relationship S1, rate now, when you get to the return demonstration, when I'm listening to sister, I don't have to do, I don't want a whole minute to go by, a whole minute to go by, I don't want to waste time. So when you're listening to the heart, you've already done vital signs. So you felt a pulse, you felt a pulse, now you're listening to the heart, you're boom, 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 boom. You're saying, oh, that's consistent with what I got on my vital signs, which were, and I already told you, which were like 48 or 50, whatever the case may be, all right? So rate, you can say, consistent with vital signs, consistent with the number that I got on vital signs, if there's no faster or slower than what you got as far as your vital signs and your rate. Yeah?
So we're listening to the rate on the heart.
You're listening to the rate on the heart, right? Okay? So I'm covering the general parameters for you. So the rate should be consistent with vital signs, and you said 50 to 90, and that's correct. Rhythm, take a wild guess. What should we say about rhythm? Regular or irregular. And if it's irregular, that's when we get into, I talked to you about atrial fibrillation. Remember that? What is that, God? Irregularly. Yeah, irregular, I know what you mean. Irregularly irregular versus regularly irregular, all right? Now, when you get to advanced med surg, I'm going to show you heart blocks. There's first degree, second degree heart blocks, third degree heart blocks, and those come as a regularly irregular rhythm. You say, that's classic. Now, those you need an EKG to confirm what you're suspecting there. But with this atrial fibrillation, that's the one you can say, just with my pulse and listening to the apical, I can tell, yeah, that's irregular, that's classic atrial fibrillation. And you'll be right every time on that without an EKG. Okay, let's see, strength. Strength should be, what do you think? When you're listening to heart, what do you say? What descriptor would you put on that? Strong versus moderate versus weak. Strong, moderate, or weak. Okay. And then any extra heart sounds? You should hear what? When you listen here, you should hear what? Boom, boom. Up here? Boom, boom. You heard 2 beats, crisp and clean, no murmurs, no extra heart sounds, none of that stuff. That's what we're looking for. Okay, so when you get to the midterm exam, guys, I'm giving you an answer to the midterm exam. Are you ready? Buckle up. You need to know these basic parameters that should be done on any healthy patient when you're listening to their heart. You follow me? These are the parameters. You got it? You follow me? So what's lungs? Rate, rhythm, depth, effort, use of accessories, and animations, breath sounds. What's this? Look, breathe right now. What's that? Appropriate relationship S1? Rate, rhythm, strength, and the extra heart sounds. Got it? Got it. Okay. All right, let's see. Okay, so we did that. Sister, I kept you up here too long? Good, you're done. Thank you. Next one. You've got the structure, you've got the assessment we're going to do, inspect, palpate, auscultate, whatever, and then you've got the parameter here. So, first is the precordium. Precordium is a fancy word for that area of the chest that overlies the heart. What's the precordium? That portion of the chest that overlies the heart. So this area right here is my precordium. Is this my precordium? Good. No. Is this my precordium? No. This is my precordium, where the heart is at. Okay, so that part of the chest that overlies the heart. So we're looking at the precordium, and we can have the patient sit up, or we can have the patient lie down. Either one. I'm not going to have my patient lie down right now. So sitting up will do, and we are going to inspect the precordium, and I inspect the front, and I inspect from the sides. If I have the patient lie down, it's really easy to have the person lay down and look from the side there. What am I doing? I'm examining, looking for the intercostal spaces that, any pulsations that might be there. So, you tell me, if I laid Madeline, if I laid my patient down, or she's just sitting up here, and right in here, I see her heart doing this. Look at this. Look at that. In between the intercostal spaces. Does that strike you as strange? Yeah, you're saying, is there an alien in there? So if it's doing that, that tells you the heart is enlarged. So if you're feeling or seeing, and we're not feeling yet, but if you're seeing pulsations in between those intercostal spaces, that means you've got cardiomegaly. That means there's an enlarged heart. So what do pulsations show you? An enlarged heart between the intercostal spaces. right? Now, also in the epigastric region, that if I saw a heart actually moving in there, then that would tell me that I've got an enlarged heart situation going on here, all right? So, now, there's an exception to that. Let me see, if I had someone who was very, very skinny, I won't pick anybody up, I don't wanna embarrass you, but if there was someone who was very, very thin, very skinny, and they had this kind of thing going on, I'm sucking it in big time in order to do this, all right? You see all that skinniness going on right there, right? So there's all that skinniness going on there, and is it possible that you might see a little bit of movement in the epigastric region? Yes, that is not a pulsation, all right? So I'm not calling it a pulsation. I'm saying you can actually see some movement, like there's a baby in there, or there's a, you know, ever seen a baby with the arm or elbow come through? Ever seen that on a pregnant mom? Yeah, no, it's fun to see. So if you actually see, you say, there's something underneath there, that's the enlarged heart that's expanding down there and beating underneath there. That's not the same thing as a real thin person. You'll see that it kind of fluctuate a little bit with the beats. Am I making sense to you? I know it's going to happen. You're going to see this. You're oh, there's a pulsation. That means they have cardiomegaly, and it's not. It's because they're a real thin person. All right. Okay. Let's see. We did that. Okay. So yeah. So I inspected. Now comes the. You're done, Madeline. Madeline, you're done. I'm going to keep her. She can be lying down. It's easy when the person's lying down, but I'm going to keep her sitting up so you guys can see what's going on here. Now, what we want to do is find the intercostal spaces and the angle of Louis. Remember the angle of Louis or the sternal angle? Remember that whole thing? I said you're going to be using it a couple times. Here's one time we're going to be using it. So what I want to do is palpate and find the locations of the intercostal spaces. And where I'm going with this person is the second right. This is where we're going. You can write this down. We're going to the second right intercostal space. We're going to the second left intercostal space. We're going to the third intercostal space. We're going to the fourth intercostal space. Then the fifth intercostal space. We're going to move over in the fifth intercostal space out to the midclavicular line. And that's where we're going to finish up. That's the area that we're heading in with these intercostal spaces, both palpation and auscultation. We listen. So your listening sites are going to be the second right intercostal space. We're going to palpate there. We're going to listen there. Second left intercostal space. And by the way, this is along the sternal border. This is not midclavicular line for these guys. This is along, that's tight along the sternal border. So second right, second left, third intercostal space, fourth intercostal space, fifth intercostal space, and then we're going to end up in midclavicular area. You know where I'm headed with this. If I'm going to fifth intercostal space, midclavicular area, and I am feeling that, I'm going for the point of maximal impulse. I'm looking for the apex of the heart. I'm feeling the PMI, the point of maximal impulse. If I'm listening, what am I listening to? Remember when it was irregular, we'd say go to the strongest part of the heart and listen to that place. And that's called the what? The apex of the heart. It's called the apical pulse. That's the strongest place where you can listen to what's going on with the heart. So far so good. Have I confused anybody? All right, so far so good? All right, so these are, yes, good, no? Okay, good. All right, so far so good. Let's see, so here's where I find the locations. We come and we go to the sternal notch. You know that, everybody play along with me. Go to sternal notch up here where you push it and once the gag you, go there, find that, and then work your way down. Now, what am I on? What am I on right now? The maneuvering. And I'm looking for, and women have terrible angle of nubes. I'm going to guesstimate right there. I'm guesstimating right there. And so where the manubrium articulates with the sternal body, you've got the sternal angle, or the angle of Louis, and you come over, and yep, there you go, and you've got a rib there. You feel your rib? You've got a rib there. And slide down into the little space there. That little space is the second intercostal space. All right? And I'm going to palpate that, find it, and then I'm coming over here just across the way, across the sternal body there, to the second left intercostal space, and then I feel a rib, and then I come to the third intercostal space, then I feel a rib, and that's the fourth rib, and then I come to the fourth intercostal space, and then I feel a rib, and then I come to the fifth intercostal space, and there's where you're at. You okay?
Yeah.
Surviving this thing? Okay? All right. Now, I've found the locations. And then I can come over to the PMI and come over here. I found my locations. I know where I'm going to put my stethoscope now. But before I auscultate, I'm going to palpate. And so the next thing to do here is to palpate for pulsations and thrills. A thrill is a vibration. When you get to cardiac, you know you had tactile fremitus here, and what was it? 99, 99. What are you feeling? A vibration. And what they call it in the respiratory language, they called that what? Tactile fremitus. Put your hand on your chest here, Pledge of Allegiance type thing. Put your hand on your chest and say 99. 99. You feel the vibration. What's that called? That's not a thrill. What's that called? That's called tactile fremitus, right? Now, when you get here, go to find the second intercostal space. On me, here it is. Put your finger there. Palpate that. You know, try to lay those down like so. Don't go boom like that. Try to lay that down like so. And do you feel any vibrations there? No. Don't say 99 because it's not respiratory now. Now you're trying to feel the beats. All right. 1, do you feel any pulsations there? No. Do you feel any vibrations like the 99? No. Now, what would a thrill feel like? I'll tell you what a thrill is in a minute, but what would it feel like? Go 99. That's what a thrill feels like. All right? But the patient doesn't say 99. Every time the heart beats, you get this vibration that feels like when you just said 99. So who's vibrating? Not my vocal cords. What's vibrating is the heart. When you have severe murmurs, a lot of regurgitation, or a lot of stenosis, or a lot of turbulence going on there, then that's going to create a vibration. You tell me, what would be the worst murmur? One that doesn't have a thrill, or the one that has a thrill? What would you guess? Which one's worse? One that has a thrill is worse. Okay? So that's why we pay attention to thrills. So, and also pulsations. If I got a pulsation on my patient up here, what's that tell you? If there's a pulsation going on there, what's that tell you? The heart is enlarged. Cardiomegaly, an enlarged heart. So if I'm feeling pulsations up here, that means I've got an enlarged heart. If I feel a vibration here, what's that tell me? I haven't even listened to this patient yet, but I probably have a whopping murmur. I'm going to talk to you about how you grade murmurs, grade 1 through 6. And a 6 is one you can hold the stethoscope 1 inch off the chest, 1 inch off of the precordium, and you can still hear the murmur. Sound like a big one? Yeah. And those big ones like that, when you put your fingers down, you palpate that intercostal space where that valve, whatever valve is faulty, that valve that's causing that problem, you'll pick up a thrill. That is a state board concept. They want you to know what a thrill is. So when I say thrill, you go right to what system? What organ?
Cardiac.
Cardiac. When I say tactile premises, you go right where?
Respiratory.
To the lungs. They're both what? They're both what? Vibrations. One's coming from vocal cords. The other one, now, remember a consolidated area. One's coming from vocal cords that this received it, amplified it, and is really sending out to you. So the vibration on the affected side is up, down, normal. Up, down, normal is what? The affected side, pulmonary consolidation. It's going to be increased, decreased, or normal compared to the other side? Increased. All right. Over here, what does increased mean? What does increased mean? It doesn't mean consolidation on the heart. It's not talking about consolidation now. What are we talking about? Turbulence as valves are either leaky, allowing fluid to sneak back through, or they're stenotic and they're restricting blood that's wanting to come back through there, and it's creating this turbulence. If blood can go down through there easily, you don't hear very much of a sound at all, other than the valves closing. If there's obstruction there, then what fluid does is it creates vibrations as well, and you'll feel those vibrations with your palpatory technique, and that's called a what? Not a tactile premises, but a what? Thrill. That's what a thrill is called. Are you with me? Am I making sense, you guys? All right, so now what we want to do is check for any pulsations and then any thrills. Do you remember on tactile fremitus, a really good way, not for the finger pads, a really good way to pick up a vibration is what? It's not with your finger pads. Sister's doing it. Sister Jim's doing it. Look here. Coming right here. All right? So pulsation, this is how it's done. Pulsations, negative. Thrills, negative. Over the other side, where am I going now? Second what? Second right. Second what? Left. I'm going down to the second left intercostal space. All right? And what am I doing? On my patient, what am I doing? I'm checking for what? What am I doing right now? Pulsations, all right? And watch this little sneaky thing that I do to maintain the patient's modesty and make sure you know, she knows I'm on the up and up. Well, watch what I do. How do you like that? See what I'm doing? We wouldn't want to do that, right, all the way down through there. True? True? Right. So what do? Watch how sneaky this is. Patient says, oh, that's a good examiner. Look what they did. I did it sideways. You follow me? All right, so what was that all about? Look here. What am I checking there? Was that bony structure on the side there? What I just... Thrills, right? And then down here, the third intercostal space, pulsations, what would you expect? Negative. Thrills, see what I'm doing? Thrills are, what would you expect? Negative. Fourth intercostal space, trying to feel for any cardiomegaly, any enlargement of the heart. Pulsations are? Negative. Thrills? Negative. Fifth intercostal space, also known as a tricuspid. I'll get through all those listening sites for you. Also the tricuspid, feeling there. Pulsations are? Negative and? Thrills, negative. And then we work out to the last place, which is that midclavicular line. Careful. Here's where it changes. Come over here, feel right in there. Fifth intercostal space, midclavicular line. Pulsation should be? Positive, because it's not just the apex, it's not just the fifth intercostal space, midclavicular line, but it's also called the P apical, yes. It's called the PMI, which is, what's that stand for? Point of maximal impulse. So if you've got a healthy person, you should feel a faint tapping going on there. Okay, so what do I say about pulsations there? Positive. So in that area, when I'm examining the patient in that area there, I say, positive pulsations. How about thrills? Should I get vibrations out of that? No, shouldn't get any vibrations out of that. And then how we do that, you can usually with the examiner, you're off to the right side of the patient. So the way I would do that is come over here and come up under here like so, and put a hand underneath there and see if there's any thrills going on there. And negative for thrills. All right, done. Thank you. Yeah, because sculptatory site, it's also the aortic location for picking up pulsations and thrills. This is written for you in your PowerPoint if you download that for cardiac. But this first one is the aortic. And where's the aortic at? Second right intercostal space, right sternal border. Second right intercostal space along that right sternal border. Your next one over here. Oh, take a wild guess what valve is you hear best here, by the way. The aortic valve. Isn't that nice? So that's the aortic auscultatory site, listening site, and it's where you pick up the aortic valve the best. This over here, this is what? This is the pulmonic auscultatory site. This is where you pick up what's going on with the pulmonic valve the best. Now, guys, does that mean the pulmonic valve is right there? Take a wild guess, anatomy. Does that mean the valve is right there? If I put a needle, like you did in the back anatomy, physiology, you put a needle in there, do you really find the pulmonic valve right there? No, pulmonic valve's down there a little bit deeper. I'll show you a picture of that, how that works. But this is the site where you hear what's going on in the pulmonic valve the best. Right? Then the next one, the third intercostal space down, is on the left, on that left sternal border. Left sternal, when I say sternal border, that means you're hugging tight against the sternum, right? You're in the space, but you're hugging tight. You're hugging tight against the sternum. Yes? You agree? You with me? All right. So in that third intercostal space, that's where you're hearing aortic and pulmonic. So it's kind of like the bi-state area. You know, you're picking up what's in the aortic and the pulmonic. And then when you go down the fourth intercostal space, some textbooks will just skip right over the fourth intercostal space. I don't. I say, hey, it's intercostal space, listen to it. And that's where you're starting to pick up on what's going on in the tricuspid valve. Right? Tricuspid right side, mitral the left side. So if I put my needle in here, will I find the tricuspid valve right there? No. But the tricuspid auscultatory site, the fourth intercostal space, that's where you hear more of what's going on with the tricuspid valve now. And then when you come down to the fifth intercostal space, that left sternal border, fifth intercostal space, left sternal border, that's the tricuspid auscultatory site. So right there, fifth intercostal space along that left sternal border, that's where you hear what's going on with the tricuspid valve the best. Okay, am I making sense to you so far? And then you finish this thing off and you take a couple little baby steps over there, because I don't want to miss what's going on in the ventricular septum. You know, I don't want to do boom, tricuspid to mitral. Why do I want to do that? Because what's in between those two valves? The ventricular septum. You've heard of ventricular septal defects, where there's leaks going through there. The kids, the babies can get that. So we don't want to miss that. So we take a couple, I call a couple of little baby steps over, like a half inch, and a half inch. And now where am I at? Where have I landed? Fifth intercostal space, fifth intercostal space, mid-clavicular line. I am now at the apex of the heart, and it's called the mitral auscultatory site, or the mitral space. The mitral auscultatory site. And you can take a wild guess what you hear best there.
The mitral valve.
The mitral valve. And which valve is the loudest of all the four? The mitral. It's got the highest pressure system, right? You've got that left ventricle that slams shut, and that ventricle contracts, and then the mitral valve slams shut in order to perfuse blood to the whole body, right? So that's going to be a high pressure system. Do you agree? You've got to send it up to the brain. You've got to send it down to the toes. Send it up to the brain, down to the toes. And you get a nice pulse down there in the pedals with this love dub. Should coincide. So this side over here is sending it up and down. It's a high pressure system and it's loud. That's why we go to the apical, because you're best able to hear the valves and the heartbeat at that location. So give it to me back here. This is called the what? Second right intercostal space. Right sternal border. Positive sternal border. What's that guy called? Aortic. What's that one? The third one is called Herb's Point. You're looking in the PowerPoint. Good. That's called Herb's Point. Guess who named that one? Dr. Herb. See, if you name a location, then your name will go down in history. So Herb's, fourth intercostal. No one cared about naming that one. Fourth intercostal, and then you come down to the fifth intercostal. And what's that one called? Tricuspid. Couple baby steps over. Listen, and then you end up in the mitral. Those are the sites. That's the names. And those are the valves. And there's an old one, I'm not a evolution person, I'm a creation person, right? But the evolution mnemonic on that is ape to man, A, P, T, M. Do you see it? Aortic, pulmonic, tricuspid, there's an E in there. Aortic, pulmonic, herbs, tricuspid, mitral. Those are the classic listening sites, and most textbooks will leave out fourth intercostal. I put it back in there because I like to. I don't feel comfortable skipping it. I like to hear what's going on at that region there. Your questions, Joseph.